Right, it is now 7 o'clock, so you are very welcome, everyone, to the first Health and Adult Social Services Standing Scrutiny Panel of this municipal year. Just to remind colleagues that the meeting is being held in hybrid form, so we are. It's possible that we might have some members joining the meeting online. I know Councillor Tai said that she may be able to join for part of the meeting a bit later on. The meeting's also being live streamed on YouTube, so you'll be able to watch yourself back in a while. I just want to inform members that I've received the following apologies. So we have apologies from Councillor Alexander, Councillor Tai, Councillor Raza, Connor Wood, and also Councillor Baines, but Councillor Harbhajan Cordier is here in place of Councillor Baines. So thank you very much for joining us this evening. Moving on to item number 2, urgent matters. There are no urgent matters that I've received as chair for tonight's meeting. So that brings us on to item number 3, declarations of interest. So I will start with mine and open it up to panel members. So I declare an interest as I'm employed by the Nursing and Midwifery Council. Councillor Conti.
Yeah, I'm a GP in North West London.
Councillor Mataza.
I am a GP in North West London.
Thank you very much. And Mr. Cook.
Help.
That is excellent. Thank you, everyone. I'm not seeing any further declarations. There are no matters to be considered in private this evening. So I then move to the minutes of the previous meeting. It feels like a little while ago now, the 1st of May. Can I have agreement on the minutes from the previous meeting? Great. Thank you very much. We then move on to the panel terms of reference and draft work programme. If I could just start with the terms of reference. Do you agree to the terms of reference for the panel? Agreed. Thanks. So we then look at the work programme. Any comments from members of the panel on the proposed draft work programme? We do have a question from John Moffat from the Ealing Reclaim Social Care Action Group. So Mr. Moffat, would you like to come and use one of the microphones just so that everybody can hear you online as well? Perhaps, yeah, that'd be great. And Gule, would you just turn it on? That'd be super. Thanks very much.
Thanks very much. Yes, it's regarding the closure of Ealing Care Line and under the work programme. We are concerned that there's no mention in the work programme of a lessons learned report on the closure of Ealing Care Line and the current service provided by Harrow Care Line. We've been waiting for this report following assurances at previous panels. Is Healthwatch still commissioned to carry out this study, and will the report be added to the work programme at a later stage?
Thanks for that question, Mr. Moffat. So as chair of the panel, I can confirm that the Ealing Care Line item was considered twice by this panel during the previous year. But Kerry, did you want to supplement that with any information specifically in relation to Healthwatch?
Thank you, Chair. As per the reports that we've brought to this panel in the past, the performance, we're very satisfied with the improved levels of performance with the new provider with the telecare service. In terms of Healthwatch, I think the current situation that Healthwatch are experiencing will cause some difficulties and challenges in order for us to plan any further papers or inspection, and review type activity at this stage.
Thanks very much. Any questions or comments from panel members on that? Can I get agreement for the work programme for the year ahead then, please? Agreed. Thank you very much. So I move on to, which is always a pleasure, the appointment of co-op team members. We have a little lineup of co-op team members that we're seeking to co-opt to the panel. David Crawley, Project Officer at Healthwatch Ealing, Lorraine Charlton from the Ealing and Hounslow Community and Voluntary Service, Alan Cook, a long-standing member of the panel, a member of Ealing Healthwatch, and who's very active on health matters in the borough. Gulay Hanid, the co-chair of the Carers Co-Production Board, and Connor Wood, co-chair of the Autism Co-Production Board. And I think what I would say in terms of the experience that these colleagues bring, it really enriches the quality of our scrutiny. So seeking agreement from members that we wish to co-opt again. Is that agreed? Thank you very much, everybody. So I now swiftly move on to item 7. Anna, we're coming your way on the Health of the Borough report. So you're going to provide us with an overview of the third Health of the Borough report, and this demonstrates the council's key achievements during 24-25 in its bid to tackle inequalities and improve the long-term health and well-being of residents. And I should say that Councillor Newstub, the cabinet member with responsibility for this area, is hoping to join us a little later, and we'll be happy to take questions. But Anna, coming your way.
Thank you, Chair. Good evening, everyone. I think I've met everybody, but if I haven't, I'm Anna Bryden, Director of Public Health, and I think today I've been at Ealing 6 years, so that's a nice way to remember, and it was this hot as well. I've put up the slide, so hopefully you can see the full papers in the pack and the cover paper, and the slides we'll share with Sam afterwards to share online. I hope you can see this okay as I go through. I'm not going to put it on slideshow because it doesn't work on Teams for me, so hopefully this is large enough for everybody. So just to introduce. So we brought this paper here before. For those that might not recall, this was a specific commitment from the Cabinet in the Council Plan to really have a focus on how the entire Council and all the different directorates are contributing to addressing inequalities in the borough and improving the health and well-being of residents. So not just a kind of traditional health kind of projects or initiatives, but wider than that. So this year we've learning from the last couple of years, including the discussions we've had here at Health Scrutiny. We've tried to make this the format a little bit more accessible, a little bit shorter. It's about to be printed in this kind of magazine format that the communications team have been using for the other comms across the council, so people can really pick and choose what they want to look at rather than seeing a 90-page report and not going there. There's some great things in there, and we're also using those articles that have come from across the council to really raise awareness of initiatives, events during the year as well. So you'll see some of these pop up again later in the year. And what we have really tried to do is kind of put a bit of a what's the offer to residents, what's the call to action, so that people can really think it's relevant for themselves. So just to say, we have looked across the council plan and the health and wellbeing strategy. So there's lots and lots of topic areas and work that's happening under those areas, and just really asking those council colleagues to share the good work that they're doing that other people might not have heard of. I remember the first year that we published this, so with lots of things in there that even I never heard of that were great work across the council and really focusing on reducing inequalities. So just to say, we've got links to the council plan across lots of these. I won't go into these slides too much detail, but there's very much a focus on fighting inequality, tackling the climate crisis, creating good jobs. And then hopefully you'll have seen the health and wellbeing strategy. Again, there's an awful lot of a lot of the things that we're talking about today helping deliver this strategy. So really thinking about putting communities at the heart of everything, systems and structures that leave no one behind, and connecting the building blocks of health and wellbeing. And I'll just touch on that latter one here. This is a diagram that we use with our new research collaboration across the council, our CVS groups and our academic partners. So really thinking that everybody has lots of things that support their health and well-being, and different factors combine to influence health. So it's not necessarily just kind of access to health services or your personal behaviours. So for example, not smoking, physical activity, but it's everything around you that really helps improve your health. And taking some of those out can really add to those inequalities that people experience. So things like housing, transport, green spaces, education, income, and really thinking about how councillors and partners can influence those blocks and really fill those gaps for our communities and try and improve the equity. So you'll see when we publish this that we've got 22 articles, so it was bigger than we intended because there's so many good things going on. So really work looking at those building blocks of work, so things like community involvement, education, employment, income, green spaces, safety, thinking about support for some of our most vulnerable residents, so people experiencing homelessness, people with substance misuse and mental health conditions, sanctuary seeking residents, people living with HIV. And then there are a number in terms of our kind of healthy behaviour, so supporting people to stop smoking, have good oral health and keep active. I won't go through this, but there's lots in there. So I'm just going to touch, Chair, if it's okay, just on three of the case studies in there, just to give a bit of a flavour. And obviously, people, when they look at it, if there's any questions afterwards, we're happy to answer those. So the first one we published was a Ealing Health Inequalities Dashboard. Bless you. Interestingly, this actually came out of the discussions when we brought this to Scrutiny 2 years ago. So there's a lot of emphasis saying this is really good work, but what are the trends? What are the data? How do people access that? And particularly talking to our community voluntary sector colleagues, there's a lot of data that's almost locked up in big documents historically, and we've been trying over the last few years to really put that in a more accessible way. So we've got our Ealing data website that's got lots and lots in there. We've tried to cut that data by 7 towns as well, so people can really look at local areas and neighbourhoods and see what that means for them. And then this inequalities dashboard was a real chance to have a look at both health indicators, including from our NHS colleagues, and more the building blocks of health indicators that you can cut in different ways and people use it. And that was really coming out of some of the discussions here of saying, where's that accessible data? How can we get it? So that's something that we launched a few months ago, and it's something that's developing over time. And I think especially with our research collaboration work, it just gives another opportunity to really bolster that. So that is online already, launched a few months ago. This is just what it looks like. I won't go into detail, but there's different, the top left colour categories is access to healthcare. So there's a range of indicators in there, population health, and then the kind of building blocks of health. And one of the bits, especially with an analyst background that I've spent many years trying to perfect, is the top right bit is really, really useful. So it says what the data shows. It gives you a really nice interpretation of the data. It adds a kind of like specialist element in terms of is it particularly different or not from, say, England or London data, so you don't have to be able to analyse this data yourselves. And people we know already, especially our CVS partners, are just copy and paste that into funding bids and things, and you can cut it by lots of different ages, by age, sex, and particularly by towns, which I think people are finding really useful. The next one we did was it sounds like a really simple project, but it's one of these things that takes a long time. So for people who are sleeping rough, the vast majority have some sort of physical health condition and far less access to advice and treatment for any health problems. They might not be registered with a GP, might have had issues before, stigma around cleanliness, etc. So we work really closely across with our substance misuse service, Hope for Southall Street Homeless, and a lot of partners, and run this drop-in every Tuesday at St Ansel's Church. So that's hot meals, clothing, showers, etc., and help with filling in GP registration forms, which came out really clearly during the COVID vaccine push as well. And what we have done more recently is work really, really closely with lots of our NHS colleagues to try and set up some health outreach services. So looking at eye health, teeth and feet health as well. And so that's really got going in the last few months and has been really, really well received. And it's something that I think that partnership work really shows the importance of supporting vulnerable people. And it takes work and it takes a lot of practical planning, but it's really, really worth it and a really great kind of human approach to this. And then just the last one was cost of living support. So obviously over the last 2 or 3 years, we've been really trying to push on this across the council, and again working with lots and lots of our partners. You know, relatively high levels of poverty, and obviously cost of living has really affected people's well-being, and how they're able to achieve their aims in life. So the team is absolutely tiny but does fabulous work, really partnership focused, raising awareness of how people can access things that are already out there, particularly around benefits, practical help, food banks, etc., and really trying to support residents into kind of more long-term financially sustainable way. So the 5.3 million figure there is really about helping people access benefits and things that they're eligible for but might not be accessing. Shopping vouchers to low-income families, and especially in terms of school holidays, local assistance fund, and 300,000 as well, also to some of our local voluntary organisations to support people directly in the communities. So just finally, Chair, just to say we've been sharing this around, but the comms team have been making it look great and really accessible in that new format. So that's going to be published by the end of the month, and there'll be communications sent out, and some of those case studies will be followed up separately. So bringing it here was just for the third time, was just really for the panel to consider the breadth and extent of the work that the council is doing to improve health and wellbeing, reduce inequalities. Obviously, I'm here and Kerry slightly, and Councillor Newton when she arrives, really representing the council, but this is covering so many different departments, including lots and lots of our partners back here and in the CVS and Health Watch. So really happy to take any questions back. I think with this item more than others, there might be a case of me taking some questions, taking them back, and then feeding them through Sam and Anna Marie for any more details. Thank you.
Thanks very much, Anna, and totally appreciate that you may need to take questions away, given the kind of breadth and depth of the report. Can I just start by thanking you and also welcoming the Health Inequalities Dashboard? I think that was a really good addition to the report, and obviously that follows the panel's feedback as well, so it's really nice to see. I'll open it up to questions from colleagues. Goulet first, and then Councillor Conti.
Is it possible to ask someone to go over the health and inequality dashboard with me, because I'm having trouble accessing it, and for better understanding, it can be online or face to face. If you can arrange that, that would be excellent. My second question is, in the Together in Ealing Health and Wellbeing strategy, given that the strategy repeatedly highlights the importance of systems and structures that leaves no one behind, the need to tackle health inequalities, how is the Health and Wellbeing Board specifically identifying and addressing the unmet needs of unpaid carers, both adults and young carers, and of disabled people whose voices and specific services need to appear notably absent, are notably absent or underrepresented in this document? And thirdly, given the ongoing cost of living crisis, what monitoring is in place to assess whether carers are absorbing more care responsibilities due to service limitations, and what support is being provided to offset that burden? So the report outlines impressive financial support schemes and more than 100,000 shopping vouchers to low-income families and caregivers, but doesn't address how shrinking services may shift more responsibility towards unpaid carers. Thank you.
Thanks very much, Goulet. So Anna, I'll come back to you on those three for starters. Thanks.
Thank you, Chair. Thanks, Goulet, for the great questions, and thanks for providing them in advance as well. So in terms of the dashboard, that's absolutely fine. So I will share with you afterwards this very great analyst called George, who's happy to take you through it. We have presented it at a number of partnership groups as well, especially including a lot of our community voluntary sector reps as well. So we are kind of out there trying to get people to use it and trying to encourage that, but very happy to take questions and feedbacks on how it can improve. So very happy to sit down on that. We have got some data on unpaid carers data, but because of the way it's formatted, it won't fit into the dashboard as it currently is. So it's a really great something that we really need to consider for inclusion. It's something that we wanted to get out there. We kept adding different indicators and it kept shifting in time, and we just needed to launch it at some point. So it's absolutely something that's live and really want to add to. So I'll take that away and contact you directly if that's okay, Goulet. In terms of the strategy, again, great question. So we and Kerry might want to add this. So Ealing Adult Social Care launched a carer strategy in June. I think we took that through Health and Wellbeing Board recently with some of our carers co-presenting in terms of identifying carers early, enabling carers to have a family life, maintain good health and maximise income. There's been lots of awareness raising taking place in terms of events and co-production, including young carers in some of those partnership spaces. And I think the next steps is to review the carers resident journey to improve the assessment pathway. And your third question, Gule, around the cost of living crisis. We've got a new tool that's called the Low Income Family Tracker, LIFT, which our cost of living team is actually leading on with lots of our analysts and lots of our different council services. So that's really showing across lots and lots of different indicators that we use to measure low income. There's about 27,000 families on our households on there, and about just over 3,500 are classified as carer households, but it's likely obviously the informal carer numbers are higher. The carer strategy really is about supporting carers of all ages to maximise their income and realise potential, and we've doubled the number of carers receiving direct payments over the last recent periods. There's re-ablement training as well to unpaid carers, and that enhanced wellbeing offer with partners, including kind of talking therapy. So next steps are really looking at enhancing the digital offer for assessment and information and advice. Thank you.
Thanks very much. Councillor Conti.
Thank you. It's a really interesting report, Anna. I just had a few questions. I guess one is the link between sort of the stuff that you're doing and then the outcomes on the dashboard. I guess it's in terms of evaluating sort of the success of individual schemes, and in particular, sort of, I guess, three things. So obesity in children at year 6 is, if you go back all the way to 2008, it's barely changed. Similarly, in terms of sort of smoking prevalence, has gone up, and I think the gap actually between Ealing and North West London has increased since 2017, and alcohol admissions as well have gone up. So I guess in particular in those three areas, in terms of evaluating sort of what the council's doing, are we doing the right things? Actually, are either the schemes that we're running not working? Do we need to think about them in a different way? For example, in the dental admissions, that's actually gone down. So I guess you would say, well, actually, what we're pursuing more broadly seems to be bearing fruit. I just wonder how because in the actual report, it's quite difficult to sort of determine individually how those schemes are performing, and do we think that they're the right schemes, and do we need to do something different in some areas?
Anna.
Thanks, Councillor Conti. That feels like an entire discussion in itself. I'm very happy to take that aside. I think excellent questions. So I'm going to just put it into two parts about evaluation and prioritisation, if that's okay, and obviously come back if I haven't fully answered the question. So prioritisation, so we look at the outcomes all the time, especially when we're writing strategies and feeding that in needs assessment process, which is statutory, also including budget setting. So we've just gone through last week another round of budget setting with our public health grant, which isn't everything we do, but it's a really important part of that. So even in that, we've been prioritising exactly some of the things you've just been mentioning, particularly around alcohol emissions that we're very high on and have been for a long time. Falls prevention is another one that we're quite often come up as a high indicator, and we've had services, but we're trying to put something in place longer term. Smoking prevalence, we've just had our contract signed, which is great for our longer term service with West London Trust. So again, that's something that we were prioritising specific groups around people with mental health needs and people who are pregnant, but actually we've been really lucky with the national government prioritising that area and giving local areas some funding for that. So that is something that we are very aware of, and really thinking about the inequalities in that. There's some groups where the figures are going down, but others where we know through lots of data that they're particularly high. Child obesity, again, is something that in Ealing and linked to kind of adult obesity and diabetes as well, something we're really aware of and try and prioritise work, and that some of that is services. So we do have, say, weight management services for children and young people, and we're looking to expand that to older, to the adolescent age, which currently it doesn't get served well. We're looking at developing an adult weight management service and have got some funding set aside for that. But there's, I think, almost more importantly, or as importantly, we've got lots and lots of partnership work happening on the ground. So looking at those building blocks of health. So we are just currently finalising work on a child. I can't remember the phrase, apologies, but it's essentially a child weight management and prevention strategy. So that's really work and an action plan, really concretely working with lots and lots of council departments and partners to make the environment as healthy as it can. So in schools, out in the parks, including kind of access to different activities during summer for people on low income, etc. And in terms of evaluation, it's something we're really keen on pushing that forward. So we do have lots of, for say our straightforward services that we commission, so say sexual health or substance misuse services, we have lots of contract management, lots of KPIs, lots is reported up through national programs. So that's there, and we kind of monitor that and see how things are going, and we do kind of agree to amend services as we go. I think more broadly across the council, we're trying to push the evaluation culture. So our health determinants research collaboration that we've got external funding for to really set up much more of a strong, robust research and evaluation culture in the council and with our partners. We're just started year 2 of that, so really pushing that forward, and it feels like it's starting to show progress, which is great. We've got lots of new roles in place. We had an event a couple of weeks ago with fabulous, I think it was 26 community researchers that have been trained up, so out in their communities learning about what works well and feeding that back in. So it's something we definitely look at. I think in terms of the evaluation of specific initiatives, that's something we could maybe take away for next year's report or think about that. We also cover things like that in things like our health and wellbeing strategy. We have an annual update report which goes in September, which looks at what's been happening in the last year, how's that been going. But obviously everything in this report is absolutely fantastic, but is only a very small bit of what we all do to contribute. So it's a bit of a flavour of some of the initiatives and programmes and areas of focus rather than comprehensive. Thank you.
Thanks, Hannah. Councillor Conti, any follow-up? No. So I've got Mr. Cook, then I've got Councillor Mataza, and I've got Councillor Steed, followed then Mr. Crawley, and you might get a second bite of the cherry Goulet, but I'll see. Mr. Cook.
Thank you. It goes on actually from part of the answers you've already given to Councillor Conti. What concerns me is childhood obesity. One of the issues that I've got is that overweight and obesity are 2 different characteristics. In some reports, they're reported as individual items, and in other reports, they're lumped together. But my big concern is that over a period of the last 12 years, there's very little, if any, movement in year 6. In fact, actually, if you look back to the JSLA report for 2011-12, in fact, to the current, it's gone up from 27% to 33% plus. That is concerning, because obviously in adult life, those things that have happened, building blocks in childhood, actually cause problems. And the other thing that is interesting from the report and is a bit of concern is the fact that when children first appear in school, their weight seems lower, and by year 6 it's gone up. So are we actually spending money in the right place, and are we've got the right issues to cover those problems?
Anna, over to you.
Thank you. And I'm very happy to kind of come back with a larger item on this as and when it might fit in the work plan. I think it's a really important area. I think, and Councillor Conti mentioned the data as well, during COVID, an awful lot of places, including us, saw a real increase. It was a real spike. So after a bit of a decrease, and that's levelled off a little bit just in the last year of data, but it's still early days to say whether that's sustained. I think that shift between reception and year 6, I think, is really important. I think that, again, that's quite common. Ealing's not an outlier in that, but I think it does show, these are children in our schools, in our settings. How are we supporting them to have that healthy environment? So that work I just mentioned, really refreshing that wider strategy of how we maintain healthy weight through childhood and into adulthood, I think is really important work. It's not that that work isn't happening, but I think it's really thinking about what is the contribution of all those different teams and partners to that, and how can we resource that well. I think that's really important, and that's where we're saying things like the kind of weight management in that older, the kind of adolescent age group, I think has been a gap, and is something we're really looking to refund that. We are going to be updating our overarching children's joint strategic needs assessment in the next year, and that will include obesity as well as lots and lots of different measures in there. So that is something we can share later. And I think your point about the different measures is fair. So we can check, everything we write, we need to be checking that it's actually clear exactly what measure whether we're related to. Hopefully that's okay for now, but it is something I'm very happy to kind of maybe bring back as a kind of draft forward plan for later, potentially into the next few months. Thank you.
Thanks, Anna. Is that okay? Yeah,
more
of course.
bit. You actually mentioned 8 primary and secondary schools taking part in this special cookery thing. Obviously, it's too early to assess results from that, but is this possibly the way forward to expand that to more schools?
Anna,
Thanks, Chair. Thank you. I agree. We are also looking at, we've had a really great initiative called School Super Zones, which has historically been funded across London. It was in Brentside School. We had it here, and that's a really great example of showing community-led action. So it's going out to schools and all their surrounding communities to say what would help this be a healthy environment for families and wider. So it might be looking at cookery lessons or growing areas in the schools. It might be looking at upskilling catering staff to thinking about different kind of culturally competent healthy foods. Might be looking at the walking routes to school, cycling routes, etc. So again, we are trying to reprioritise funding to roll that out to more schools, because I think that's such a valuable way of working in partnership with communities. And I can take that back. If there's anything further on that, I can bring back and share more information.
thanks very much, Anna. Councillor Mataza.
Thank you, Anna. I just would like to make a comment on childhood obesity, that children need to learn really very earlier on the way they eat and what type of food they eat. And I think childhood education is also a very important in the schools, especially the primary school, and they are very receptive at that age. I think perhaps we could include that. My question was regarding the rough sleepers and their health needs. One of the major issue is the communication with them. Obviously, they don't have an address, and they don't have a fixed abode to get registered with the GP. Some of the practices do register them on the practices addresses. However, the communication to them and getting their health needs addressed is very important. Is there any way we can improve the communication between the homeless people and the practices? Thank you.
Thanks, Councillor Mataza. Anna.
Thank you, Chair. If you're happy, Chair, I can answer initially around our services. I don't know if you might want to ask VJ O'Neill at the back to add from a GP practice point of view, or we can come back afterwards. So I think one of the big things is the drop-in centres, I think, are a really great way of communicating. So people are coming, there's lots of things offered there. They've got relationships with a lot of those workers. Hope for Southall Street Homeless. So I always get that acronym mixed up. I think they do fabulous work, and they work a lot with other partners in that area as well. Our substance misuse service also is in that partnership, and there's a lot of people that they have really long-standing relationships with. We've really increased our outreach work through that service. That's been a really great. We've had some of our local funding and national funding put towards that, really thinking about where are people in our communities, how are they accessing if they're not coming into our services. So that's been a really, really good piece of work. So if you want, I can share a bit more information on that. Thank you.
That'd be really helpful. VJ or Neha, it feels very like you're very far away there. If you'd like to address the point, that would be great.
Yeah, sure. So, in terms of the homeless and registrations into GP practice, we've done quite a lot of work in Ealing and across northwest London, looking at this particular area, and there's been some innovations nationally as well, particularly in relation to online registration of individuals in terms of GP surgery. They don't now have to physically go into a GP surgery to fill in a form and to register. A lot of practices now will have posters up in display with QR codes to help people to register online. We have just recently started to put the posters up in London North West Hospital, in all the wards, and in maternity and other areas like A&E, so that people are able to register without having difficulties. We have also got a commitment for every practice in North West London to sign up to the Safer Surgeries Commitment. The Safer Surgeries Commitment is around breaking down all of the barriers and challenges of registration. There's no need for any form of ID or proof of address or identification ID to register with a GP surgery. Historically, there have been difficulties with proof of address and demonstrating your right to NHS services. That is no longer necessary, so anyone can register with any GP, and they don't have to provide any proof whatsoever. The GP IT systems have now accommodate no fixed abode in terms of the registration, and that's always been an issue around what address can a homeless person put for the registration purposes, and so that has been changed as well. And it's been really important that we try and ensure that all our homeless cohorts of our population in North West London are able to register with a GP. Yes, there's more that we can do. I think where we need to do more work is really in terms of that outreach work with the homeless individuals, because they may not be aware about the difficulties, or in fact less difficulties in terms of registering with a GP surgery. So historically they may have had quite poor experiences, and hence that learnt behaviour has resulted in them not even attempting to register with a GP surgery. So we are really trying to make changes going forward.
Thanks very much, Vijay. And Anna, any follow-ups, Dr. Matarza? Thank you. So I turn to my Vice Chair, Councillor Steed.
Thank you, Anna. It's a really good report, and lots of links and lots of bits of information that I wasn't aware of, and taking me down various avenues and stuff like that is really good. Thank you, and your colleagues. One of the things that just strikes me in the beginning of the report, there's quite a long piece about the council's plans for the 7 towns. And I'm just sort of wondering, the report shows the very good work of various council departments working together. I'm just wondering whether, to some extent, might that come into conflict with power being devolved to the 7 towns, and whether some of that very good work of departments working together, I mean, it may not happen. I'm just putting it out there, whether one strategy somewhat dilutes another strategy, kind of thing.
Anna?
Thank you, Chair. I'll start off, Councillor Steed. That's okay. I don't know if Councillor Newsted might want to add. It's a really good question. It's not how I would see it. I think when we look at those building blocks of health, how people's experiences happen, it covers so many different things. I think the joint working between council departments, at least over the last few years, I think is stronger than it has been, including with our community voluntary sector partners, our statutory partners, our NHS partners. I think is really strong here. And I think you need that to be able to work better with your 7 towns, so that people aren't just accessing one bit of the service for, say, their housing needs, or their GP practice, or accessing the library or something. So I think working together is the way to work with towns. I think there's an awful lot more co-production happening in the last few years as well, which is really strong. We've got some really great community voluntary sector partners in our research collaboration, etc., and that was really viewed by the national funding body as a really great thing that Ealing are doing that others aren't doing in the same way. So I don't think there is a conflict there, but I think it's really thinking about how we do work with communities. What does community-led change look like? How do we, going back to Councillor Gunter's question, how do we evaluate that? Is something that I'm really really keen to push forward, that especially with the resources from the research collaboration, so that we can see what good looks like, and all these different types of initiatives, schemes, programs. We can really get a great plan going forward into next council's plan about how do we measure that, what does good look like. So it's something I'm really keen we move forward. Thank you.
Councillor Newsted, did you want to supplement? Thanks.
Thank you, Chair, and apologies for being late. I had another event. Yeah, I don't really see there's anything contradictory. I mean, when we talk about 7 towns, it's not necessarily that we're going to replicate every single thing we do in Percival House in the 7 towns. It's that we are, our ambition is to show up in our communities much more effectively. And I think when we look at the work of the NHS and the integrated neighbourhood teams and placing things at a much more local level, it's very clear to me that connection, integration always happens at the local level. And the more that we can do that effectively and realistically and in good faith and good heart, whether it's our social care, working with our NHS partners, and the broader public health initiatives, I think it is about people working in their localities to understand the local population and the health needs, and really working together with VCS and with all the other partners on the ground and local businesses to really address some of those. So it doesn't seem contradictory. It seems potentially a very strong driver of that integration at a local level. Thank you, Chair.
Thank you very much. Councillor Seed, any follow-up?
No.
No. Excellent. Right, so I've got David Crawley. Thanks.
Thank you, Chair, and thank you, Anna, for all this great work. There was one piece in the report that stood out to me that I think is very important, and that is the work of the primary care access team in training about addiction and giving naloxone training to GPs in the borough. I think that's essential work. I know that work will save lives once implemented. And my question was, is there going to be a sort of progress report on that work in a year's time? Can we see how many GP practices have taken part? Things like that. Thank you.
Thanks, David. Anna.
Thanks, David. I think that's such a great example of that joint work. Again, it sounds so simple, but it's taken time to work out the practicalities of embedding those teams within our practices, and that's really moving forward. We have been looking at expanding that as well into some of our other areas with high needs. So hopefully we'll be able to share that over the next couple of months as well. In terms of progress report, I'm happy to, for the practices we already have, I'm happy to bring something back and maybe share it over as part of the written responses, if that's okay, David, and then we can keep that in the loop as well. Thank you.
Thanks very much, Anna. I should also say that actually an Ealing resident, Ben Toomey, was involved in the pilot of naloxone in Birmingham. So you know, it's good to see that we're following suit and rolling that out. I think it's a really important thing. Gule, we've probably got time for a couple more questions from you before we move on.
Thank you. So my question is, what tailored mental health support is being co-designed specifically with unpaid carers and also disabled persons to help prevent stress, crisis and long-term burnout? The report focuses heavily on mental health among children and the general population, but carer mental health is not addressed. So ensuring mental health strategies including preventative and peer-led offers designed with and for carers. So the next question is, in care pathways such as dual diagnosis or substance misuse, how are carers being meaningfully included in care planning and service feedback loops? So the report describes improved integrated services, but does not give any reference to carer involvement. So carers are often the main coordinators of complex care, especially at home. So we just suggest embed a culture of treating carers as expert partners in joined up service delivery. The next question is, how are carers from marginalized communities such as BAME, LGBTQ, disabled or young carers being supported through inclusive and culturally competent approaches? So Ealing's diversity is rightly celebrated, but the report does not explore intersectional carer challenges. So overlapping identities can intensify disadvantage and drive inclusive carer support that reflects the full diversity of Ealing's population. And the last question, are unpaid carers currently represented on town teams and local engagement structures, such as those under the Your Voice, Your Town program? So the program aims to embed local voices in decision making, but carers' involvement is also unclear. So carers offer grounded insights into what services and environments are most supportive. So advocate for formal carer representation on community planning and funding panels. Thank you.
Thanks very much, Gule. You certainly got those out quickly. So thank you. Anna Kerry.
Thank you, Gule. Let me come back with you with those responses. I don't know, Kerry might want to add any specifically. So, great questions. I think really important. I think two of them, especially the first and last, touch on that intersectionality. It's something we're really keen, especially with some of our kind of normal tools like our needs assessments, that we really try and think about that. So we are trying to we are working at the moment on thinking about, instead of just say topics or kind of disease topics, so diabetes, we are thinking about kind of communities. So we obviously did carry out the carers needs assessment informing the strategy, and I think it's something we can really build on. We are looking at some of our what we call inclusion health indicators as well. So we are thinking about drafting strategies looking at potentially, say, sanctuary seeking residents, LGBT. I know is one of your later questions came out again, kind of homelessness, etc. So I think in terms of the specific question, Guli, about the mental health support, when we talked with our partners, I don't think there's a specific mental health project that's aimed at supporting unpaid carers or people with a disability. It doesn't mean that they're not accessible services and that those needs haven't been taken into consideration, but that's something we can kind of take away to our partners. And I think you're just jumping to your possibly third question about marginalised communities and those intersectionalities, I think the same answer. So we are trying to look at that with the data. So it's not kind of, let's look at diabetes here, let's look at carers here, let's look at LGBT. I think it is trying to kind of be a bit smarter with some of that. That might not always be easy in some of our kind of data sets and things, but I think it should be through our strategy. And I think the co-production boards and things are a really important part of pulling those out. Your second question, Gule, about care pathways such as dual diagnosis and substance misuse. So this is really strong in Ealing. So RISE, which is our local adult substance misuse services, that phrase you used about teaching carers as expert partners is exactly what they really try and do there. So really families and carers bring those unique insights, and their involvement is a really core part of planning that recovery process with service user consent. So an example of this is our naloxone training sessions, where carers are equipped and empowered to intervene if there is an overdose situation. We also work alongside families to develop safe alcohol reduction plans, so really kind of think family approach to care. Our local service hosts one of the first service hubs nationally, offering a dual diagnosis anonymous groups of carers. So if it's something you'd be interested in finding out more, or the panel, we can share some more information. Thank you.
Thanks very much. Anna, Kerry.
Thank you, Chair. I think part of the discussions we've been having around the co-production boards is about how is representation achieved for seldom voices and voices that are seldom heard in the community, and we're continuing to push forward with the co-production boards as an adjunct and an additional support to the Your Voice, Your Town, because sometimes the seldom heard voices are not heard as strongly in the Seven Towns type space.
Thanks, Kerry. Coming back to you, Anna.
Apologies, there was your other question about some of our town teams and local engagement. So again, I can just do a quick verbal update, but we can share more details offline if that's okay. So when the council's been doing their discovery phase with the Your Voice, Your Town programme, there was a targeted focus on working with specific community groups, which did include carers and parents and unpaid carers. So that really fed into how the programme's developed. As it's moved forward, each town is setting its own ground rules, and a lot of that has been around being inclusive, making sure voices are heard in there, and really thinking about unpaid carers and other groups. So if anybody would like to join those groups that we feel isn't in there, we can kind of contact them to ensure that they can fully contribute. We also had some connections made. There was a recent direct payments event in Percival House, so some connections were made with Your Voice, Your Town through that as well, and really specifically asking for people with lived experience to really feed into that next critical phase of development. So I can share some of that written as well. Thank you.
Thanks very much, Anna. So I think, colleagues, we've had a good discussion around that item. I'm not seeing any more indications. So I'm suggesting, because we are running to time, that we wrap up. In terms of the discussion, I think I've heard that in terms of the report next year, we'd like to see a tightening of the kind of specific measures that are contained within it. And Anna, I think you undertook to come back to us with kind of an evaluation around some of the specific initiatives as well, which I think will be really helpful. Big theme of the questions this evening was obviously around childhood obesity. Councillor Steed and I have just been looking at the work programme for the year ahead, so we're proposing a specific item on that for the January meeting, because it kind of wraps up as part of some of the other work that's coming to that meeting. And I think we'll probably invite the Children and Education Scrutiny panel to come along for that item as well, so that we can have a joint conversation. So is there anything else that I haven't captured there? Councillor Dear.
Yeah. I ask a question, Anna. You mentioned about diabetes. Diabetes and hypertension is, I think, particularly in Asian communities, are quite a high rate. What are the new interventions or early interventions to prevent preventative measures? Have we planned? Is there any new plans are being considered? Thank you.
Anna, can I come to you?
Thank you, Chair. I think diabetes particularly, we are currently working on a needs assessment, so working with a lot of our partners on developing that, because I think it's been a while to refresh that, and I think it is such an important issue in Ealing. Hypertension, we are also looking at opportunities across London where there's work happening there as well, but it might be something I might need to come back to written, if that's okay. Thank you.
It's lovely. I think if it's okay, we'll go with the written item, just written response, just because we are now running to time. So I saw the indication, but yeah, sorry, we do need to move on. Okay, so we're now moving to item 8 on the agenda, which is the Ealing Health Watch annual report. Obviously, since we last met, we heard the news about the closure of Health Watch England, and just wanted to pass on best wishes to you and colleagues at Health Watch, David, because I know that it will be an unsettling time for you. But thank you for the huge amount of work that you've done on this report and that colleagues continue to do. So I'll come to you for an overview now, if that's okay.
Yes, thank you. And just before we dive into the details of the annual report, I'd like to address the news about Health Watch's abolition. Your Voice in Health and Social Care, which is the organisation that runs Health Watch Ealing, as well as other health watches in London, have anticipated some sort of change. We didn't think it'd be full abolition. We thought it would be a restructure. But we've already begun reviewing our current delivery model through co-production and consultation. This process ensures we continue to work closely with our local communities and strategic partners to explore new models that support effective and inclusive community engagement. At this stage, we are not going anywhere until a law is passed in Parliament. We have been told we won't expect full closure until the end of 2026, the beginning of 2027. So we are not aiming to change our current aims and objectives of services in that time. I'm confident, having prepared for this transition, we will be well positioned to maintain continuity for our strategic partners without significant disruption. On a personal note, working for Health Watch Ealing over the last 2 years has been one of the honours of my life. I've come to fall in love with this borough, and it is my sincere hope that we can continue to serve the people here for many years to come in whatever form it may take. Now, all that soppy stuff's out of the way. Annual report. Over the last year, we supported more than 5,411 people to have their say and have their voice heard, and to give communication out to them. We had 4 staff during the 24-25 year, and we were supported by 22 volunteers who we could not do what we do without them. 5,174 people share their experiences of health and social care with us through our various projects and patient experience program. 237 of those other people came to us for advice and signposting. We published 11 reports this last year, including our Enter Review reports on mental health hostels, the Enter Review report on the Community Diagnostic Centre, and our patient experience reports. I'm going to go through some of the highlights of the report. We collaborate with a network of local health watchers. We attend meetings on a North West London level. We raise concerns to the ICB about low level of engagement on the same day GP access plans, which resulted in them extending the consultation to ensure resident voices were reflected in decision-making processes. We help support the ICB to raise awareness of the 10-year NHS plan consultation, especially to seldom heard people and those most likely to face healthcare inequalities. We attend key strategic meetings, including the Health and Wellbeing Board, co-production and patient experience meetings, the Adult Social Services Scrutiny Panel, amongst others. Some of the projects we did this last year that patient experience first, sorry. I've lost my place. I apologize. Yeah. So, as a part of our work, we host a mental health inpatient experience program, where we work with the West London NHS Trust to identify key areas in mental health wards, making better care for patients in Ealing, Hammersmith and Fulham and Hounslow. We spoke with 430 patients during this inpatient program. We visited the Lakeside Mental Health Unit every month in Hammersmith and Fulham, the Hammersmith and Fulham and the Lakeside Mental Health Unit in Hounslow. We use surveys, one-on-one chats and group discussions to understand the experiences, care, facilities, and activities that these people experience whilst in the ward. The Trust worked closely with us and we gathered patient feedback to provide 45 practical recommendations to improve patient care and experience across both units. Some of the main highlights from our recommendations include clearer communication between patients and staff, regular ward meetings and written care plans to make treatment and discharge information easier and clearer to understand. Cleaner, safer words. Patients were concerned about the cleanliness of the wards, which led the Trust to improve pest control and provide better bedding for comfort. Better support after leaving. Once discharged, the Trust has introduced new resources like discharge booklets and family involvement plans to help patients settle back into their communities. Patient experience in Ealing. We conducted 201 healthcare visits, the majority being visits to GP surgeries and a large portion at Ealing Hospital. We've also, in this last year, started to conduct patient experience visits to the Community Diagnostic Centre. Things we heard, 53% of users reported challenges with the availability of appointments. 84% stated their overall satisfaction with the quality of treatment and care received. And 82% reported concerns about the lack of staff available during their hospital visit. With the push from GP surgeries to implement more online booking and less reliance on the 8 a.m. rush, we've seen mixed feedback on how patients feel about this. This is an adjustment period and it should be monitored. Through our program, it's allowed us to engage with a large bisection of the community in different areas and provide feedback to GP surgeries to help shape and improve services in the borough. So on the independent research we did this year, the homelessness experience in Ealing, We spoke with 27 rough sleepers and asylum seekers to understand their experiences using the NHS. We did this in co-production with the third sector partners like Hope for Southall Street Homeless and REAP, Refugees in Ethical and Effective Partnership. We did one-on-one in-person interviews to understand the experience of what it's like to use the NHS as an individual in these cohorts. 8% of individuals told us that they felt that they'd been treated differently because of their living situation. 30% told us they did not know how to register with a GP. 33% told us that the support they wanted most was help finding and sustaining employment. We did an enter and view program where we visited mental health hostels where some people, after they are discharged from the wards, go to help rehabilitate and then go on to more independent living. We spoke with 23 residents and 14 members of staff and 5 managers about the experiences living and working in these hostels. Their voices helped us to understand how the system works, what they liked and what could be improved. The most common request for improvements from residents was to gardens and outdoor spaces and activities. The average stay for people we spoke with was 3.7 years. We visited the Community Diagnostic Centre for a second time. First time was the year previous, where we went during the early opening phase. This last time, once it was fully opened. The average travel time for those we spoke with on the day was 40 minutes, and the average time to get an appointment was 3 weeks. We recognise this is not that long after it fully opened. Those metrics may have gone down. The other project we did was supporting the social understanding of flu and COVID-19 vaccinations. We help promote seasonal vaccines such as flu and COVID-19 boosters throughout Ealing, focusing on target populations like those experiencing homelessness, those experiencing asylum, and other unheard communities. We reached 170 people through 4 events hosted at Hope for Southall Street Homelessness Day Centre at St Alden's Church, the Hilton Hotel in Ealing, and the Tamil Temple in Ealing. We distributed multilingual flyers designated to raise awareness about how and where to access primary care services. We conducted one-to-one interviews with 34 people and collective qualitative insights on vaccine knowledge, attitude to motivations and barriers. We assisted 30 people in receiving vaccines on site on the day by directing them to where they had to go or to help book an appointment with a local pharmacy. Some final notes before I open it to questions. I would be remiss if I did not mention the very important work of our volunteers. They gave up 128 equivalent days, donating £11,000 worth of their time based on the minimum wage. And we are a small employed team at Healthwatch, and if it weren't for our volunteers who do so much good work, we would not have been able to accomplish everything we have. And that is the overview of the annual report. I will take questions, comments, and concerns.
Thanks very much, David. Huge amount of activity. I'll open it up for questions from colleagues. Yes, no worries. So I'll go Goulet first. I'll take it. Yeah.
Thank you. While the report commendably covers work with mental health patients, asylum seekers, and people facing homelessness, there is little to no focus on the lived realities of unpaid carers, especially in terms of access to services, mental health support, and involvement in decision making. This omission represents a significant missed opportunity to address health inequalities and improve patient outcomes and uphold the principles of co-production. what can be done and how can this be captured to ensure that unpaid carers are firmly represented in Health Watch governance structures and decision-making forums, including the local advisory board groups, health and well-being board engagements, and mental health strategy consultations? Second question is, with so many residents reporting problems with GP access, what steps have been taken to understand how this specifically impacts unpaid carers who may be managing both their own and others' appointments under time pressure? So the report says that 53% of patients report difficulty in booking GP appointments. For carers juggling multiple roles, this can have a serious knock-on effect on both their health and well-being, and for themselves and for those who they care for. So we just advocate for a care-friendly lens in digital access reforms, e.g. online booking and e-consult systems, including flexible slots and triage consideration for carer status. I've had that experience of making a call at 8 a.m. in the morning and being number 48 in the queue and having other people at home who I care for, and that has a big impact. Although they do say call back, the callback can be at the time when I'm doing something, a hands-on thing. So that's what I wanted to flag. Thank you.
Thank you, Guli.
David.
Oh, sorry. I jumped the gun. We recognise the importance of unpaid carers. They play such a vital role in the healthcare of the community. Our patient experience programme is designed in such a way currently where we capture the experience of anyone who's at a GP practice or hospital. We recognise that that does not capture everyone, which is why we are doing this consultation to see how we can better improve our engagement practices. I'm sure we do have responses from carers because we do ask that question when we are collecting patient experience. It's just not presented in a way. So I can take that back and have a look through our data set. And yeah, going on to the GP appointments issue, yeah, when we're doing this consultation to see what our future delivery methods can be, let's have a conversation outside of here to see how we can best capture the experiences of carers. Thank you.
So I've got Kerry and then I've seen BJ. If you want to make your way up for responding, but Kerry, I'll come to you.
Thank you, Chair, and thank you, David. First point is a accuracy point. I nearly fell off my chair, David, when your annual grant for government is 3 million.
No, it's not. Anna Marie can tell you, we were working to deadline on this. The accurate number is
377,000 I've calculated.
Yeah, we received for this year from the annual grant for government £120,000, and we had £4,800 in external funding. This was corrected and the up-to-date versions on our website.
That's fine. It's very rare that there's an inaccuracy in anything that you do, David. So I just wanted to make light of it.
Excellent, thank you.
Today, thank you. Two much more serious points, Chair. I think the work that Health Watch have done with regards to the Enter and View programme in mental health hostels is a response to the tragic murder of Jenny Foote a number of years ago in Ealing, who was working in one of the mental health hostels. This sort of support within a formal framework, I think, is absolutely key to support local government and our partners improve outcomes for residents. And, you know, the tragic event, death of Jenny Foote is something that we still feel as an organisation. I think it's really important that we recognise that ongoing support from Health Watch in terms of responding and maintaining safety and improving outcomes for local people. As I've mentioned previously, the work that Health Watch did with us through the Enter and View programme in the PFI care homes was outstanding. I think it was about 1.5 years, 2 years ago, where we saw significant improvements in CQC ratings. But just wanted to highlight those. The loss of the Enter and View programme, I think, will be one of the things that we'll feel most sorely in terms of the function of Health Watch in the future. But thank you, David.
Thanks, Kerry. VJ.
Thanks. I just want to first of all say, David, I'm I'm pleased to hear that at least HealthWatch will hopefully be here until 2027, and whatever the the future version of HealthWatch is for Ealing, because they have played a major contributing part in terms of being the voice of local residents, particularly in relation to NHS provisions and NHS services. So that feedback has been really invaluable for us all. In relation to your question around unpaid carers and access into general practice, I want to try and answer that question in twofold. One, from a proactive approach. So in Ealing, particularly, we have a local enhanced scheme within general practice where we invite all our carers to come for an annual review. This annual review is to look at their concerns, listen to what they have to say, identify any unmet needs, and to identify any long-term conditions which our carers may also have. I guess the biggest challenge we have in general practice is to be able to identify carers accurately. Clearly, we will code it into the GP system, but unless we are able to code it, we can't then invite them for an annual review. So that is ongoing work that we continue to endeavour. In relation to reactive access into general practice, yes, there are challenges. We are all fully aware of that. We are working in North West London, and particularly in Ealing, in relation to our access specification and programme, particularly in terms of having more responsive and triage and navigation. It is difficult to identify every individual call that comes into a GP practice to prioritise. So you will have waiting times, particularly in peaks in terms of activity. But we do now have cloud-based telephony in every practice in Ealing. So the functionality around callback has been a really positive change, so that people can carry on with whatever they're doing, and then to receive a call back once they're back on the list on number 1 or number 2. Yes, that may be inconvenient, particularly you gave the example of you being busy with one of your clients, but that is just the nature of where we are in terms of trying to manage all the needs of all our population in a much more universal way.
Thanks, Vijay. Councillor Conti.
Thank you. And thanks for the report, David. And obviously, it's good seeing everything in sort of one sort of report in terms of sort of highlighting the extent of all the work that HealthWatch does. I think it's really disappointing to hear about, obviously, the decision to sort of close or HealthWatch. I guess obviously it seems some way off in terms of when that will happen. I guess from your point of view, what are the risks potentially that opens up by not having HealthWatch? Because it's been around a really long time in terms of giving patients a voice, in terms of feeding things back, and how do you envisage things, the risks it might pose by it not being there or not being in its current form? And I guess the second thing was in terms of it, I think it was really helpful seeing as well the feedback from the sort of findings in terms of what the different organisations have done. Did HealthWatch find any resistance from any organisations or any sectors in terms of going in to do it and sort of being less receptive with the feedback at all?
Thank you, Councillor Conti. So what is currently proposed through the NHS 10-year plan is to divide the responsibilities of HealthWatch. Our healthcare research side would fall to the local NHS, and the social care side to the council. I and many of my HealthWatch colleagues think that our organisation plays a very important part in being an independent voice. We like to call ourselves a friendly antagonist, where we can be honest and truthful with what patients tell us and give our feedback to organisations. In terms of resistance, not really, no. Most GP practice, not all GP practices and healthcare facilities, pharmacies, community diagnostic centre are very happy for us to come in. They like to have that scrutiny at that level. The only time that we've ever faced in my 2 years at Healthwatch, resistance is some places where we want to do an interim view are unsure of us and what we are intending to do. They think that we are like on the same level with the CQC, so there's some resistance there. But when we come in and we explain that this is to see what is going well and what could be improved, we don't get any resistance then typically. They're happy again for that scrutiny.
Thanks very much. Any further questions? Gule.
Sorry. So the report mentioned that Healthwatch helped promote seasonal vaccines such as the flu and COVID-19 boosters within the borough of Ealing. So was the unpaid carers included in this promotion drive, and did you come across any issues they faced? Hearing from all communities, key findings, no mention has been made on the difficulty in the community patients acquiring the COVID booster jabs this year. There was a significant delay in the delivery of the booster jabs to the community pharmacies. And did you come across such a situation, and how did you handle the information? And was the deadline date extended for the COVID boosters this year?
David.
So in terms of that last part of the question, the difficulty with COVID jabs, the vaccine program and the delayed delivery of booster jabs, I can't really answer that. That's outside of my remit. And again, a part of this program and where we can improve in the future is that we talk to people who are there at the day. I know as a part of our work plan for next year, we are doing that examination into Careline just to see what patient experience is like there. And we intend to talk to carers as a part of that. And we've already talked to some carers so far. But yeah, I unfortunately I don't have an answer on the delayed delivery. Thank you.
Thanks. That's something that we could take away though. So thank you. Any further questions from panel members? No, in which case, thank you very much, David, for that report. Any recommendations from colleagues at all? No, in which case, thank you again. Sorry, I do have one question from the Ealing Reclaim Social Care Action Group. That's poor chairing on my part, but John, if you'd like to ask your question and David can respond. It's brilliant.
We echo the value of Healthwatch's work, and we welcome the report, which is well-researched, comprehensive summary of health issues in Ealing. We're a bit disappointed, though, that yet again social care issues have not been covered by satisfaction surveys or interviews. Care and support services like domiciliary care, direct payments, respite care and dial-a-ride are examples of social care where there are significant numbers of service users who may be hard to reach as are living in their own homes, but who could be part of a telephone survey. Will Healthwatch, notwithstanding the recent news regarding Healthwatch, will Healthwatch and also Scrutiny Panel be able to reach out and listen to these parts of the community? Thanks.
Thanks, John. David.
Thank you, John, for that question. So we do take social care very seriously. Your Voice in Health and Social Care. The Enter Review program was designed to reach out to facilities that deliver social care, like hostels, care homes, so forth. This year, we are going to be visiting non-CQC regulated facilities and the day centres that are in the borough. I've forgotten the names of them, I apologise, but the one, yeah, Michael Flanders and Cowgate, thank you guys. In terms of reaching out to these hard to reach individuals, again, we are developing a co-production model to see how we can improve our engagement methods. I would love to do more, but there is also just the issue of capacity at Healthwatch with now 3 employees and our volunteers. I'd love to talk to every single person in the borough but we only have what we can do. But we will see how we can improve that in the future. Thank you.
Thanks, David. Kerry, you just wanted to comment on that.
Thank you, Chair. Just to add that the adult social services, we have a range of survey inputs through national requirements of what's called the ASCOF survey. We also have survey information, and this isn't necessarily about hard to reach groups. This is more generic activity. We also have the local resident survey that's done of local residents by the council as a whole, but there's relevant questions within that regarding social care attitudes and how people believe adult social care meets needs. Also, in terms of domiciliary care providers, certainly through part of the CQC registration process, there's an expectation that people survey people who use their services, and it's certainly something that we do within the internally provided council services. And they're all in our performance reports, which I think is coming in the October cycle. Chair, thank you.
It's like we planned it, Kerry. I think that's excellent, and we'll be able to get into those in a bit more detail then. Thank you. I don't think I've forgotten any other questions, so we'll now move on. So item 9 on the agenda is the CQC and the LGA inspection reports update on the adult services work plan. Kerry, it's over to you for that one.
Thank you very much, Chair. This is a updated position following a request from this board for a position following the CQC inspection of July 2024. CQC rated Ealing Adult Social Services as requires improvement during that period. However, during January 25, as part of our preparation for the CQC inspection, we engaged with the LGA to carry out a peer challenge process, and we asked them to come back to review our progress in December of 2024. And the commentary from the LGA was that we've made outstanding progress in the preceding 12 months against our, since they'd previously been to inspect us. The attached report sets out the detail of the CQC inspection outcomes and the ratings, which are included on page 149 of the pack. It also talks through the LGA peer review commentary. We set out within the report high-level progress on slide 154 of the pack, which we've tried to simplify to make it more accessible to local people, that talks through the flow of people's experience in accessing services provided by the council. We then, moving on to page 156, sets out the performance of the KPIs set by the council, which includes some of the ASCOF data that I mentioned earlier. We then move through into a high-level update in terms of the action planning that's been implemented by the department in response to the CQC inspection outcomes and the advice and support from the LGA. Quite a lot of detail here, Chair, but happy to take any questions. Thank you.
Thanks, Kerry. As always, it's really helpful how transparent you've been about the work plan, and it enables us to kind of fulfil our role as the scrutiny panel. I'll take questions from colleagues. Look into this side of the room, Councillor Conti, and then I'll come to you afterwards, Gule.
Thank you. It was my question really on the graphs and social work assessments and OT assessments, because there was a lot of lines, a lot of boxes, and I actually found it quite difficult to interpret what was going on, because it was about max waiting times, median waiting times, numbers waiting at the end of the month. Obviously, with social work assessment, it looks like there's been an improvement. The numbers are going down. The OT assessments seems like really for the majority of this year, it looks like it's been pretty static and the same. I was wondering what's happening with that, and what particular sort of is my interpretation correct? But also, if it is, what particular sort of steps are being taken to try and address that? Because it looks like there was 985 people waiting at the end of June, and in December it was 942. So it's not that doesn't look like there's been much change in that.
Harry, over to you.
Thank you, Chair. Thank you for the question, Councillor. Social work productivity has improved. It's a constant battle. A lot of the work that's been done within the productivity space within the social work teams has been use of technology and AI to support the process. As you can imagine, demands are very high across both professions. The significant challenge that we face in Ealing, but also across London, is capacity in terms of occupational therapists. Make it extremely challenging for us to impact on the waiting lists. We review and triage everybody on the waiting list on a regular basis to make sure that people are reprioritised for assessment. But part of the work that we're implementing currently, Councillor Conte, is a review of our pathway and process to see if we can support quicker response times, because we know the sooner that we can support people, the less demand there will be on the service in future, and it promotes their independence, well-being and their ability to remain independent within the community. We've been through many cycles in Ealing of throwing chunks of money to bring in external partners to deal with the waiting list. We can't keep doing that. We need to find some solutions. And the good news part of the solution that has been developed is that we've launched community OT surgeries. We had our first one at the Michael Flanders Centre this week, which means local people can get easier access to OT assessments, and it's more productive because we can support more people. That's part of a programme of work to try and reduce the impacts on local people of long waits.
Lovely. Yeah, follow up, Nero.
Just so look at the table or the graph. It says max waiting times in weeks. In June was 188. So that means there's people waiting 188 weeks for an assessment. And what would the council see as the satisfactory target, and how long would you think it would take to get there?
Kerry.
Thank you, Chair. A satisfactory target is 28 days. Some of this is data issues, and some of this is some of this will be very long outstanding individuals who've got very low need that we've not got to yet. As I say, we triage everybody to ensure that there's a prioritisation.
To get the median wait currently is 26 weeks. Yeah. So how long do you think it would take to get down to 4?
I think it's going to take at least another 12 to 18 months. This is not an easy solution. Resources are challenging and demand is high.
Thanks, Kerry. Goulet, coming your way.
I think Councillor Conte has already asked the question I was about to ask. So it says assessment waits have been reduced by 50%. However, I can give you a clear example of a referral being made in September 2024. Social worker called on 25th of April, and financial assessment form submitted on the 1st of May. Package of care started on the 1st of May. Outcome of the financial has just been received today, and it has been inaccurately calculated. And the application was actually made online. From last year, the application that I made for a financial assessment, which was paper done, I received the outcome within 1 week. And so given that the carer strategy aims to support our well-being and reduce stress, how does the council justify a system that creates prolonged financial uncertainty and leaves unpaid carers in limbo for months? With all investment in digital systems and Power BI dashboards, why can't carers and families track the status of the financial assessment the same way like we can track the things like deliveries and etc. And like I thought that online submission forms are going to work much quicker than paper forms, but apparently this is a very clear example that I'm giving to you. And my second question is, you said that only 0.7% of people complain about financial assessments, but could that be because carers like myself are too overwhelmed or exhausted to even file a complaint? So how are you capturing that hidden stress carers carry while waiting months in the darkness? And 0.7% is a very, very small percentage. So I don't know how you're capturing that and what can be done about it. Thank you.
Kerry, over to you.
Thank you, Chair, and thank you for the questions, Goulet. Obviously, if it's an individual case, I'd be more than happy to discuss it with you outside. The data that's included in the report is relevant to occupational therapy and social work assessments, not necessarily to the financial assessments. It is indeed concerning if the example that you're describing is that somebody who's done a paper assessment has got processed a lot quicker than a digital assessment, because we've got a very strong push organisationally to be moving things into an online space. We're very clear within adult social care, because we deal with very vulnerable people, some people who may not be IT literate or capable, that we should have that paper format accessible still, and that people can speak to us by telephone. But I'll pick up that individual case with you directly. I think the proportion of people complaining about financial assessments is probably not representative, and I think you're absolutely right. I've come in tonight and I've spoken to a number of colleagues around the table about financial assessment concerns, so it's something I'll pick up and take away and see what more we can do. In terms of support for carers, that's something we've been discussing through the carer strategy, so Aware and the Carers Co-Production Group, and we really look to partners to develop alternative strategies and how we can enable carers to continue in their important roles. So we're far from perfect, and we recognise that. However, by engaging with people in the local people who are caring for their loved ones, that's how we aim to improve and to learn lessons and to develop services to better suit the needs of the local community. Thank you.
Thanks, Kerry. And I think on the point around financial assessments, one of the really critical things is actually if people do have concerns that they come forward with those so that they can be addressed. So I think that's an important message for everybody to kind of take away. Further questions from colleagues? Any more for any more? Is everyone feeling quite hot in the room? Gule, I'll give you the final bite of the cherry then. Go on. One question.
That would be the last question. So it's just a question. I don't know whether you can answer it or not, but can carers be identified via the e-consult that GP services are using? And can they be added to the GP records as unpaid carers? From personal experience, I literally make about 2 to 3 e-consult referrals, whereas I'm not down as a carer in my GP practice, which happens to be the same as the people I look after. So from experience and using the e-consult to make referrals for family members, it's clearly like there can be an option added there, who is making the referral. It does ask, but it doesn't, and I clearly state every time it's a carer, but you have to type that detail in. But if that was an option select, that could clearly be used as a report to extract and identify more carers. Thank you.
Kerry.
What I would suggest, Gule, is through the Carers Co-Production, because that's not my space, but I think it's something we could certainly take up with colleagues from the Ealing Partnership, where we can look to find some resolutions for that. Absolutely.
That would be great. Councillor Newstub.
Slightly off, it's very specifically to the carer point, is that I know that organisations that are commissioned by the council as well, for example, Ealing Advice Service, are proactively capturing whether someone is a carer when they call in, what is actually happening with that information, and whether it's actually meaningfully fed into any other parts of the system. I'm unclear, but it is good to know it's been captured, but it's only as good as the actions that then follow from that. But it does inform the kinds of conversations that volunteers there are having, because people are then more mindful and aware of the extra burden that they're likely to have. So it's a really interesting point system-wide, and I just use that as an illustration of how and where and how easy it is to capture the fact that someone's a carer, and then ultimately what we then system-wide do with it, because ultimately we'll be often talking to the same people.
Lovely. Well, I think that brings us to the end of that item. So thank you, Kerry, for the update. We'll continue to monitor the plan as it progresses. Item 10 is simply the date of the next meeting, which is scheduled for the 9th of October. So colleagues, I hope you all have an enjoyable summer. Enjoy the sunshine, drink lots of water and stay safe.